So good morning, everyone. Today we're going to have Dr. Rodrigo Ramirez from our department presenting on the do's and don'ts in spine surgery. We have just a few slides. Everyone knows Rodrigo, but he is some of his education. He did his residency in Mexico General's Hospital, did some work at Johns Hopkins as a postdoc, and then a master's in cellular and molecular neurobiology. And then he moved on to New York, where he did some clinical and basic spine research before going to Canada to do both adult and pediatric scoliosis at McGill, and becoming staff and an instructor in neurosurgery, and then moving to Weill Cornell in New York before coming to Mayo Clinic, Florida. Multiple achievements and awards, including Best Research Award, Young Investigator Award, Best Young Neurosurgeon, and Excellence in Research Scholarship. We have some of his selected publications on the next slide, just to illustrate his academic productivity. Dr. Buchanan, I don't know if you can show the next slide. Just some of his selected publications, tons of impact in the literature. And then finally, we have one more slide to show his H-index, which we collect for all our speakers, with 19 on Google Scholar and 17 on Scopus. So without further ado, we just want to welcome Rodrigo. And I don't know if Dr. Buchanan, Dr. Q, want to add something to the introduction.
I just want to add, when Rodrigo came, it was 2012, 13, if I remember correctly, at Johns Hopkins. He came in and spent a year with us. I saw a tremendously mature, smart, and extraordinarily gifted young scientist and clinician scientist. I hadn't seen his surgical skills. And then he went on to go back and finish his residency, came back, worked in New York for another year, and then ended up getting a license to be able to be in a fellowship that allowed him to do surgery with our colleagues. Went to do another fellowship, a surgical fellowship in Toronto, and came back to Cornell. And he was extraordinarily highly recommended by all our colleagues for his surgical skills. So I had already seen scientific skills and talent. And over the last few months, I had the opportunity to scrub in with him and do some cases with him. And I just been very impressed with the amount of work that he's done and the way he's led, obviously in his own way. He wrote a book last year. I think he may talk about it, in regards to the work that he's done. And I know that I get extraordinary compliments by the spine surgeons from working with him. I'm going to have Eric. Eric, I see you right there on the screen. You want to say a couple of words?
Yeah, it's been a great pleasure having Rodrigo around this year so far. It's, as you said, excellent surgeon, great academician. And so it's been a pleasure, Rodrigo. I'm looking forward to hear your talk today.
It's funny, Dr. Q, I also want to chime in and add, he recently, I know you wrote a textbook because I actually was looking for a technique on a surgery I was planning to do. And I came across this textbook with Roger Hartle, his name on it. And so I read through it, and obviously everybody knows Roger Hartle is one of the sort of premier MIS surgeons in spine. And so I was like, you know what, Rodrigo, you'll be doing this case with me. So I don't need the textbook anymore. So definitely a talented surgeon and a lot of knowledge. And I've certainly learned a lot from doing cases with you, Rodrigo.
And an amazing personality and a great heart, which is once again, compassionate, great heart, great team player. So take it away, Rodrigo.
All right. I don't know if you were talking about me. It sounds like a lot. I don't know if it was me. I thought it was someone else, but thanks so much. So it's great to be here. First of all, thanks for inviting me. It has been great working with all of you. I really having the time of my life. All of these personalities and people, and in this place, especially in this hospital, has been like very nice. So I will share my screen. And let me see here. And please, if for any reason I lose the connection, please text me because it's like a few slides and I don't want to keep going on this.
Right now we have the empty screen, so maybe you're sharing.
Yeah. I'm just saying because of the previous experience. So can you see the screen now with my
yeah, we got you there. Good.
So I have something to disclose. I have to acknowledge that I changed the title of this talk from do's and don'ts, and that was the first idea that I had. However, I will explain later why I changed the title of this, like in a few slides. But it was basically because of the audience of this talk, which is very important. However, first things first, congratulations, Dr. Kashyap, for the win of the Chiefs. He's the #1 fan. So disclosures,
Thank
I just
you.
added this picture when you guys were presenting and giving that amazing introduction. I have some royalties from Tima. This is the cover of the book. Soon, I already asked for I wanted to keep it as a surprise, but soon every single resident should get a copy. I just asked for more copies for this. So also another disclosure is that here you will see many personal points of view, but based on evidence. So that's what we will be doing. The goals of this talk is to reasoning of the need of awareness of deep spine principle understanding in spine surgery, and then go through the 5 of the most challenging topics in spine surgery that I consider, and then a brief summary. So as you may know, social media these days is a great tool for learning. It is a magnet for interactions. And because of this big impact, it could be perceived as bad depending on who's reading this post. So it could be as good as we wanted or as bad as we wanted. So a few months ago, this is a story that will motivate this talk. A physician that was not a spine surgeon starting posting his radiological outcomes on some cases. And he was showing like one of these cases is this one, 74-year-old male with a spinal process fracture. And then he put a screw through the bars, trying to stabilize that joint. Then the second post a few weeks later, he said this rare hybrid construction with some interspinal process devices. And lastly, he posted this one saying an 83-year-old male with recurrent stenosis after subsidence, with the highlighted point of through a 10-millimeter incision. So this is an interbody device placed by a non-spine surgeon, and obviously he received a lot of heat because of this. I guess after following all the comments on this post, this was the consensus, which it says, unfortunately, this speaks to a complete lack of surgical principles. Our most important jobs of surgeons is the time that it takes to plan the right procedure for a patient based on their symptoms, their imaging, our knowledge of biomechanics towards the triple aim, which is decompression, stabilization, and alignment. This case shows a complete disregard of all of those principles. So you can imagine that the drive of this, and because of the high impact that this post had, this post was able to gather 8 different societies and post an unanimous recommendation, which was for all of those procedures that require arthrodesis or fusion, or any intervention that will alter the biomechanics of the spine. These should be performed by either a specially trained neurosurgery specialist or orthopedic spinal surgeon. So until now, we know how all of this started, the impact of this, and now the consequence or the action after this post. However, thanks to this public library in LinkedIn, which is kind of like a professional platform, I was already interested in collecting these posts just for my own benefit, right? So I like to collect this. I have to mention that obviously in spine surgery, when you post radiological outcomes, it's just part of the story. Unless you have a way to explain verbally what happened during the entire case, everyone will find something in any kind of radiological outcome. However, for me, these radiological outcomes meant an opportunity to learn, to learn from these cases that others are posting. So in this first case, I just go through them. We just tell you what I found and what were the tricky things that I found. And in this case, it's a patient, in the first case on the top left, it's a patient with what it seems to be only thoracic curve. However, when this curve is fused, you see how he kind of had a proximal thoracic curve here, which was not corrected by the fusion. And this pose was made like that, was cropped, the head is cropped, so you don't see the head, and the shoulders are now, they were like even, and now the left shoulder is going down, the right shoulder is going down. So meaning there's some things that are not right. So you have to be very careful of posting radiological outcomes like this, because although this fusion or this instrumentation might look good, there's some things that were not addressed. In this other case next to it, this is a case with a complete loss of purpose of the surgery. This patient had obviously the purpose of this presentation is not to pinpoint at anyone in particular as a physician, but just at the things that we can learn. So this patient had a decompression only. It doesn't seem to me that this decompression was too lateral. However, as I said, I don't know the entire story, but what I know is that they decided to put some screws in this patient without what it seems to me like a justifiable fusion reasoning. This other case, as you can see, is similar with a thoracolumbar curve. There is reduced, but not accounting for the previous alignment and the shoulder alignment. And again, the head is cut because you can see how the curve of the proximal thoracic curve is going in this way. So yes, you can see that you have a big deformity correction here in the thoracolumbar curve, but we are not seeing the shoulders or the head, which is concerning. In this other case, a patient had a XLIF, which it was posted as like complete restoration of lordosis. I mean, I don't know if Dr. Fox is here, but normally I'm able to see his excellent lordosis restoration, and this doesn't look at all like that. This other pose referring as an adolescent idiopathic scoliosis case with a thoracolumbar curve where the patient was fused and that thoracolumbar curve reduced. However, as well, you can see how the head is cropped from this picture. So we don't know the status of that, and that's also debilitating. And lastly, the techniques are not suitable for every single patient, and also if they are not performed well, they could have a huge impact. In this case, this is a laminoplasty motion preservation procedure, and the idea of this is that you will keep those muscles moving, those joints moving after decompressing the spine. And you can see how one of these screws is actually right at the joint, and obviously this will fail, this will cause more symptoms and more problems. So in spine surgery, we have two different fields, neurospine, orthospine. I think as a neurosurgeons, we're still in advantage because as you can see, there's like an overlapping of these two fields that nowadays as spine surgeons, we share. So it's like screw replacement, surgical techniques, open surgical techniques. I think we are even on this now. However, we're in advantage because as neurosurgeons, we still have that microsurgery skills that orthopedics are not exposed during their training, and that probably they won't be exposed during their training. And this is because of the nerve work, brain work, and spinal cord work. So the reasoning for this talk is because if we could graph the topic complexity and volume of audience into one graph, I will show you how this is how it probably look. When you talk about very complex things, you will get the attention of very specialized doctors. So I saw an opportunity in this talk. That's why I changed the title, because talking about do's and don'ts in spine surgery, I will probably get the attention from the spine specialists in these groups. But I know that these meetings, especially at Mayo Clinic, Florida, have a great audience with a neurosurgeon group, spine surgeons, spine-related specialists, students, staff, and it's a great opportunity for all of those that come for these conferences to learn more about what we do and how we do it, and hopefully in the future have less mistakes and better outcomes. And lastly, I prepared this talk because of my passion on teaching. I'm passionate about teaching and sharing all of those things that were hard for me. I try to make them easier for the next generation. So let's start with the 5 challenging topics in spine surgery. I consider these 5 of the most important ones. Number 1, surgical indication. This has to be a structural approach. We have to consider as a spine specialist, the bone as an organ, not just like a place to put implants. The overview of balance and scoliosis, and I will just overwhelm you with information, but just to show you how complex this could be. The reasoning and role of enabled technologies. And lastly, research and education, which to me is like the most important one. In terms of surgical indication and structural approach. So let's focus on this. This is somehow the way I kind of like approach every single patient at clinic, or every single patient I see, or every single phone call that I receive about a patient. I have basic questions, and the basic questions are these symptoms matching the studies? Is this procedure really under the scope of my practice? Am I trained to do this? And lastly, and most importantly, can this be treated medically? So this is how I end my first batch of questions. Then I have more complex questions, which will be, okay, these patients probably need surgery. Is the patient in need of a decompression, or in the patient in need of a decompression, deformity correction, and stabilization? I think having this clear in your mind will help you focus, especially when you have other confounders, like the patient has some sort of recommendation, the patient is asking for a specific treatment, MIS, rather than open procedure. So if you focus on, again, what are the goals of the surgery? Is this surgery a decompressive surgery? Is this a deformity correction? Is this stabilization? What are we trying to aim here? And then some other personal questions. This is just me, right? It's like, what is the smallest surgery that I can offer? You can always do more, you can never do less. What is the best surgery that I can offer? What is the best surgery that I can offer in my hands, which is also very important. Like knowing your limitations is very important. So this is not only hypothetical. This is an old saying. They say good surgeons know how to do surgery, better ones when to do surgery, and the best ones when not to do surgery. However, this was scientifically proved by a group of orthopedic surgeons, which started studying the Achilles tendon surgery. They kind of like randomize patients into a group or the other, and deciding who was not going to have surgery and who was going to have surgery. And at the end, they realized that sometimes patients do better without surgery. So this is just a group of examples of my cases, just to show you what I mean with decompression, and fusion, and deformity correction. So on the left, you will see a far lateral disc herniation. This was done with navigation. I did this in New York, a patient with a BMI of 45. And this is a decompression only procedure. This patient doesn't need any hardware. This patient doesn't need anything else other than the decompression. On the left, you see, this was a surprise. This was a patient I got on call. This was a patient that was deteriorating and had a spinal cord compression due to a neoplastic pathology. Basically, after the reading from radiology, this was read as a lymphoproliferative problem. And I thought, okay, if this is the case, this is a reading and this is a diagnosis from radiology, which are the experts in interpretation of this, I think this is going to be easy. We decompress, we just remove the tissue over the spinal cord, and that will be it. My surprise was that this was a blastic lesion. It was hard as bone, and we'll have to do all of this decompression with the drill and navigation, and then fuse this patient. So this patient needs a fusion because I just remove those structures that provide stability to this segment, but I don't need to correct anything. I just put a fusion at that level to bridge or to bypass the need that I just created, right? So here we have another example, a non-displaced linear fracture in ankle spondy. These patients present with fracture after falls. And what happens here is like, they don't need apparently anything, right? But we know based on evidence that they will displace and they will probably end up paraplegic if we don't do anything. So again, these patients need only fusion. They don't need deformity correction. They probably will come without deformity, but we don't need to do a deformity correction surgery. And there's other group of patients like this one that had a iatrogenic deformity that we needed to correct and realign the head. And that's why I was talking about the alignment of the head is very debilitating, and we have to look for it when we ever try to aim for a deformity correction. So this is a case just to show you how tricky spine surgery could be. 90-year-old male with this deformity, with low back pain 10%, radiating to the buttocks 90%, with neurogenic claudication. These are his scans with a C7-9 deviated. Obviously, he has a sagittal and a coronal deformity. And these are the findings on the imaging: L2-3 compression, L3-4 compression. It's well known for those that are specialists in spine that we can find pseudo deformity sometimes. So I follow my approach. Is this patient of the need of something? Yes. Am I trained to do this? Yes. Can this be treated medically? No, I don't think so. The patient needs a decompression? Yes. The patient needs deformity correction? No, because the patient doesn't have any back pain and he's not complaining of disability because of this. So what is the smallest surgery that I can offer? Maybe an MIS LAMI, L2-4. What is the best surgery that I can offer? The same. What is the best surgery that I can offer in my hands? Am I trained to do this? Yes, so I can do it. So then we do it. And this patient end up having a pseudo deformity. So pseudo deformity, it's a problem that because of pain, they are not able to stand the way they will normally do it. And if we are not able to catch this, this probably would have ended up in a long fusion. And for a patient that is 90 years old, the complication rate in this patient would have been probably 100%. This is another patient with not the same luck. This is an 18-year-old patient with OI, unable to sit with a collapsing spine. You have to understand that the deformity is or scoliosis is a 3D problem on the axial, the coronal, and the sagittal plane. So this patient needed some sort of support, and his need is just to sit. So again, can I do this procedure? Yes. Am I trained? Yes. This patient, what kind of surgery he needs? He needs a decompression? No, he needs a correction, deformity correction. So what is the smallest surgery that I can offer? There is no way that I can do a small surgery in this case, right? So this patient needs a T4 2S1 and special modifications of the techniques to hold that bone because patients with OI are very tricky. And this was the result. This is another case, a case with syndromic scoliosis, which is complaining of nerve compression, myelopathic patient. So what do we do here? We're going to do only decompression. This patient needs decompression, but also he has a big deformity. So this is a patient that needs both. This patient needs decompression plus deformity correction. This is the result of that patient. So as you can see, the approach is very important. It's very, very important. It's one of the most important things in spine surgery. Otherwise, you will end up with iatrogenic complications or deformities. And as I remember in the previous talk, spine surgery, when someone said that spine surgery is always deformity surgery because either you are treating one or you're creating one, I think that, yes, that's partially true, but not every single deformity needs to be addressed or corrected. Bone as an organ. The bone as an organ, to me, is very important to talk about this because for all of those that are in training or that will learn more about this, not everyone knows this. This is something that it's very common to learn in orthopedic surgery, and it's very simple. It's Wall's law, Hilson's law, and learning more about bone quality. Wall's law, it's a very old principle. It's maybe like 50 years old. And basically what it says is that to make bone, you need bone contact, stability, reduction of movement, compression, and you need bone formation agents. You need to have osteoconductive, osteoinductive, or osteogenic grafts. But this is what you need to form bone. So that's what happened when I see posts like the one we see before, with no support, with no compression, with lack of all of those principles, then you can infer that most probably the surgeries will fail. And that's why this brought all of this controversy on social media. Another principle is Hilson's law. This is a very nice paper published by Dr. Spinner in Mayo Clinic, Rochester. And this is one of my posts. This is the Hilton's law says that for every pain location, there is a pain generator. The nerve that innervates the muscle skin most probably will supply the corresponding joint. And rest is the cure. So the absence of abnormal movement, fusion in this case, or casting, will ease the pain. And then I see this post from a company saying that spinal stabilization technologies with this dynamic device will start clinical trials studying patients. And my immediate observation is like, how are you going to treat pain with a hyperdynamic prosthesis? This is going to be probably very complex and very controversial. To ease pain, you reduce the you need to reduce the motion, create stability, and to have some sort of cast. Either this is external with an orthosis, with a brace, or this could be internal. And lastly, bone quality. We need to be experts as any kind of, especially neurosurgery or orthopedic surgeons, at assessing bone quality. This could be, since I explained to you, this is an organ, this is alive, this is in constant change. So we are used to perform bone density on all the patients and continues to be the standard. However, we have some other options these days. One is the computed tomography with density, and we can assess somehow how this bone will respond. And lastly, in 2023, in January, it was published that we can also obtain this kind of information with MRI, at least give some sort of correlation. So we have tools to assess for bone quality. So is it possible to do surgery with bad bone quality? Yes. If it's an elective surgery, we can do preoperative optimization. And if it's a non-elective surgery, yes, we will have to do some operative extra measures. In both cases, we can do it. We are facing some other challenges. And I can show you that the assessment of a patient that will have surgery, especially fusion surgery, is this big, right? We need to assess for every single kind of comorbidity, BMI, psychosocial issues, and nutrition issues, renal function, smoking. All of this will be part of our approach. And one of these parts of the approach will be bone density. So just to show you how complex it could be, the approach to do surgery. Bone quality, we have different tools to optimize the biology, process, and metabolism of bone. But we have to take into consideration that there are some contraindications of these treatments as well. And not every single patient will be a candidate. So at the end, we might have to do something operative. So we have some operative ways of doing this. We know because of previous research, this is an example of a publications that we had in 2018, I think, with comparing the different options that we have. And we came to a conclusion that the best graft will be some sort of biologic agent, like BMP, plus an autograft. That was our best. However, we also saw that autograft alone will be a good choice. Nowadays, we are using those in a regular fashion. We used to use high doses of BMP to try to achieve better fusion rates. Nowadays, after this publication of the impact of surgeon BMP cost awareness paper, we know that we can reduce the complications using small doses of BMP, and we can also reduce the costs. So everyone is using now biologic options. And again, if you cannot use any of those, we still have some tools like cement augmentation. This is a paper about short constructions with cement augmentation in patients with debilitating oncologic processes. And again, now you understand why this first post of a fusion, just what I would call not a fusion, but I would call a cage insertion, was so grown. Number 3, we're moving forward to balance and scoliosis. So bear with me for a little bit more of your time. This will be gonna be interesting. Balance is just the alignment of the spine and under normal conditions. So not having balance means that you are not able to keep your head over your toes in normal conditions. So this is an active process. And Dubusset in the 70s described this as the cone of instability. You heard about this before. And this is basically what happens. We have different mechanisms to keep our heads over our toes. So this is a normal degenerative process. When you are normal, your head is over your toes, you have a harmony in your spine. The more you age and the more challenges you face to keep your head over your toes, you start like bending your back. And lastly, you start bending your knees in order to keep your gaze up and your head over your toes. And this is exactly what happens. And this is the generator of pain. When patients try to compensate and move backwards, they are now using the muscles on their lower back, on their lower, and on their cervical spine to try to compensate. And it's when they cannot do it anymore, when they start having these compression forces, and then they follow this laws of orthopedics. And now what is happening? They start fusing in this positioning. So now you are dealing with a deformity that you need to correct, otherwise the patient will have a debilitating disease. Scoliosis, on the other hand, presents in different forms. This could be pediatric or adult. But some of these patients that have pediatric deformity, they will evolve into an adult deformity. So not every adult has an adult degenerative process. Some of these patients transition from idiopathic scoliosis into an adult case. And these patients are probably very challenging. We know today that adult degenerative scoliosis could be as limiting as some other very bad chronic diseases, such as diabetes, heart disease, or cancer. So this is not just like a aesthetic issue or like a mild complaints issue. This is a very, very important issue. And we also know that some parameters are correlated with some quality of life measurements. The most common, or the most famous, or the most the ones that we know more about are these three: the pelvic incidence and lombardosis mismatch, SBA more than 5 centimeters, and pelvic thick more than 20. However, every surgeon or every general spine surgeon will know about the pelvic incidence and lombardosis harmony, but not everyone will know about that these values need to be age adjusted, the value of the fractional curve in a deformity, that aesthetic outcome is relevant, especially for those patients that transition from an adolescent idiopathic scoliosis into an adult deformity. And the impact of coronal balance, the impact of shoulder balance and heel tilt, all of those are very important. There is multiple scores available online that will help you to decide what kind of surgery this patient needs. Also, some tables and some numbers about how this should be adjusted. There's multiple publications as well telling you how important the balance of the shoulders are, especially in those patients that transition from idiopathic to adult. And now you understand why these posts are very tricky, because to me, the head will have end up here and those patients end up with disability. So at the end, when you see a straight spine where they had a deformity, it's not really a deformity correction. And this is getting more and more complex as we know more. This is a paper published in 2022, at the end of 2022, which showed that when we fuse more than 4 levels, we can not only have adjacent segment disease at the top, but we can have adjacent segment disease at the bottom. And this is going back to the concept of Dubusset of the pelvic vertebra. So now we know, for example, that patients that have more than 4 levels of fusion, they could have hip degeneration. So this is a problem that we didn't understand before. And this is more and more information that we get. we're getting into the fun part, and now we are starting to land this talk, and the role of enabled technologies and new techniques. Enabled technologies are all of those technologies that will help us to have a big jump into the field. So robots are computers of numerical control. And the way they behave is basically, they will follow a mathematical pattern. So sometimes it's very difficult for us to explain to patients that a robot is going to do their surgery. I think what they need to know is that robots that are monitored by surgeons and will make their surgery safer is what is going to happen, right? You can see all of these failures of robots because they are not like simple machines, right? And this is, you can see this in the booklets of all the companies. So this is a booklet from Medtronic, which says that there's a humanistic burden of navigation, and you can see how things can go wrong. The good thing about navigation is that you still have haptic feedback. So that's why when I'm doing surgery, I tend to look into the field again. I don't trust entirely on the screen because you can make the screen look the way you want depending on how much you push on the field. So I try to always look into my anatomical landmarks again, even if this takes me like 2 more seconds during the approach or during the surgery, just because I don't want to fail. I don't want to have this one of these accidents, right? With the robots, it's the same. This was another publication on LinkedIn. As I said, this was going to be based on what I found and the things I learned online. And this is a very harsh judgment about the robots and their use. And someone posted, a fool without tool is still a fool. This is a screw that was placed with a robot. So even this multi-million infrastructure will not save you from having this kind of accident. So then you have to go back to your critical approach. And as I say, finding an indication on your critical approach is key. So is this procedure really under the scope of my practice? Am I trained to do this? So it doesn't matter if you have navigation or the robot. Are you trained to use it? Do you know the pitfalls of this kind of technology? Is this going to improve my workflow? So once you answer all of those and those are yes, then feel free to use it, feel comfortable using. They are excellent tools. Lastly, on the start of this talk is education and research. What I teach or what I try to teach or what I try to explain to all the students or all the people, the next generation after me, is this. New surgical techniques or surgical techniques in the OR is be safe first. Second, be safe and do it well. Third, be safe, do it well, and be efficient. So at the end, it's always be safe, be safe, be safe. Teach based on a failure model. So forgive, but don't forget. That's very important about your complications. Share your complications with others. I think that's very hard for surgeons. That's a very uncomfortable zone for surgeons to talk about complications. But I think these are key. Talking about complications with others, especially with others behind us in terms of training, it's crucial. So we can avoid this in the future. And remain open to learn. This is me in the bottom picture. And Dr. Wallet. Dr. Wallet is my mentor in Canada. He's an excellent orthopedic scoliosis surgeon. He can do a T2 to pelvis surgery in a couple of hours with all the work. And I'm teaching him how to do a tubular decompression in a model. And he's still willing to learn. Obviously, he did excellent. That's just his skills. And interact with other specialties. This is also very important. Like having a combined approach to the spine. This is me interacting with engineers in the spine, and you will understand how different their approach is, how things that for us are very obvious sometimes make no sense to them at all, or you will learn from them some other things. So this multidisciplinary approach, building bridges among specialties, will make us better. And it'll also make you more productive in terms of an academic achievements and patents and development and stuff. So lastly, last 2 slides, I'm gonna show you this post. So this is a classic post. This is like a classic story that every patient comes to clinic with. Hulk Hogan no longer able to feel his legs after back surgery. And this is a problem. And I will show you why. 4,691 likes, meaning interaction. A post that says he can sue them for that. So that's very concerning. And with a lower number of likes is, why will he sue them for doing their job? Some other people will have more knowledge about what's happening. And those are not even close to the likes of the first one. So this is just to bring awareness again towards that we need more, we need to do more. And we have a big opportunity to improve the reputation on spine surgery. This is a continuous work, and this is just an opportunity that we have. If things are bad, then we have a better opportunity to make it better. So in summary, number one, delineate your scope of practice, accept your limitations, follow a critical treatment selection, general spine, MIS deformity, oncology, trauma. Consider spine as an organ and you save problems. Expect and understand alignment, degeneration, biological changes, fusion, molding, instability, collapse, infection. Enabled technologies will never substitute the lack of knowledge. If you don't have the basic anatomical knowledge, you will not be able to do better with enabled technologies. And a new procedure implant will never overcome a bad indication. Lastly, share your knowledge and experience with others. And I think this will make us better as doctors. So this is Jack's Beach and Atlantic Beach. Thanks so much, guys.
Thank you for that great talk, Rodrigo. You know, I think what you hit on with this is something that I didn't really learn until after residency. And in residency, every case is a case, right? The question is, when do you not operate? And I think that's something that only comes with time, because when you show up to the OR, you know you're operating. And so unless you spend time in the outpatient, which we don't do a lot of in residency, you don't really learn that important skill set of when do you not operate. The other thing that you touch on is, you know, there's a famous quote that one of my mentors used to say about, you know, knowledge and skill set. And he says, one only sees what one looks for. One only looks for what one knows. And so the problem is, if you don't know, you don't know. And a lot of those pictures that you posted, I'm actually surprised people would post those on social media, because they've basically not adhered to any of the surgical principles for anyone who should be doing those procedures. So I think there are a number of hands up. We'll start with Selby.
Well, great talk, Rodrigo. First of all, I'm surprised no one mentioned your prolific facial hair in their introduction of you. I feel like that's a critical component of your persona. Second of all, a really great talk. You know, in terms of your section on enabling technologies, how do you determine when to adopt those technologies in your practice? You know, how do you navigate that line between being an early adopter versus falling behind the curve? You know, what's your decision-making process in that regard?
I think that's a very important question, especially these days where there's a lot of discussion in terms of like new trainees are very familiar with enabled technologies and not with the anatomical landmarks per se, because they were not as exposed to the open procedures as the previous generation. So I think I try to see it as what I put in one slide. It's like, if this technology is gonna make me better, if this technology is gonna make me more efficient, or if more importantly, if this technology is gonna make the procedure safer for me with a potential better clinical outcome, I will take the risk and I will use it. Well, not taking the risk, I will use it, right? So that's kind of like my thought process regarding enabled technology. That's why I was able to test augmented reality. I think it's a great tool. Most of us in spine surgery, we have struggled with severe degenerated patients or complex deformity, and where I can bet my hand that every one of us have said, where is the nerve? I cannot find a nerve. and you're just taking bites. And when you are using augmented reality, at least you have some reference in the microscope, and you're able to see this. So the same thing happens with navigation and robotics. I think it's just a similar situation, but I just use it, or I try to use it when I think it's going to make me safer, more precise, or more efficient. I don't know if that answered the question, Dr. Chen.
No, it does. Yeah, great. Thank you.
Rodrigo,
Can I-
sorry, go ahead, Dr. Q.
Oh, I was just going to follow up in the same line of thinking and follow the same questioning of Dr. Chen. What if the technology that you are implementing or developing or whatever your thought process is can also make other people less experienced safer? Let's say that you have all the, I mean, I look at someone like Ziago Casman, who had an amazing understanding of anatomy, and I saw him doing things with absolutely no surgical navigation, dropping down tumors and stuff like that. But the issue is that very few have that kind of gifted knowledge of anatomical principles, and yet his principles always try to invent things that would make other people's surgeons who may not have the same level of expertise or experience, or maybe he got that level because he really did so many cases at a young age and made so many mistakes that he learned. But you don't want people to learn, you know, by making mistakes. So how do you feel about creating technologies that will make other people safer? Maybe not you at your level, but other people.
So I have to mention now that Emiliano, which has been a great research fellow, he's writing a paper with Diogo as well. And I'm kind of like coaching about the future of enabled technologies. And this is something that we are talking about. I think that it sounds utopic, but I think merging the technologies into one, right? Like navigation with robotics. This is kind of like the next step. But I truly believe that with the tools we have now, we can do something better. What kind of tools? In these kind of complex cases like Dr. Goksalan is doing, now we have the possibility of using 3D printing. 3D printing is an excellent tool. So we can actually, before surgery, study the relationship of those anatomical structures to others, and then go prepared to the case. And then obviously you will be doing changes on the go, but it will not be a surprise for the first time when you open when you are doing the surgery. So merging this 3D printing pre-operative studies with probably augmented reality during surgery will make us better. I'm pretty sure you will not need to be him and have his hands and have his brains. I think to try to, and that's the goal, right? That's the goal. That you don't need to go to a specific place with this specific doctor, that you can get this training and these tools somewhere else here in Florida, for example, and then we'll just do them, you know?
I think that sometimes we forget. I remember, so I started my residency in '99, and Mike Lawton was already 3 years into his, you know, time at UCSF. And he became a gifted surgeon, but there was a lot of trials and tribulations before that. A lot of mistakes, a lot of learning, a lot of bypasses that we did that failed, a lot of stuff that was amazing. And we tend to forget that the reason why people like Mike, people like Zia get this way is because they made, you know, they learn a lot through the process. And the question is, how do we make it better so the future generations don't learn, and, you know, on patients, as you say, and these technologies can potentially enable that. Anyways, I just see Kingsley with his hand.
Hey, Rodrigo, great talk. You know, I'm not to continue to beat a dead horse. No, my question is also related to enabling technology, and really the driving force for that. Obviously, there are some enabling technology that's great, that's helpful for patients and the surgeon. But you know, there certainly are some enabling technologies that is more industry driven, and also not only industry driven and getting it introduced into medicine, but also industry driven and telling individuals that probably shouldn't be doing the case that they would normally not do without those enabling technology to feel comfortable doing those cases. What are your thoughts?
Well, that's a very good thing. That's why I said before that this sounds utopic. I think mixing technologies is going to be very challenging. because this involves patents and interests from different companies. So yeah, it sounds like a great idea to merging technology, but I don't see that happening in the near future. It will be up to us. And as I agree. I think one thing that I didn't mention just because of the timing, but I prepared it in like the full presentation, is troubleshooting. You know, you have to be ready for this. You have to be prepared as if you don't have any of these enabled technologies. I think it happened to me a couple of times during my first cases in New York alone, that things break, you know, like all of a sudden navigation is not working. And it's not like I'm gonna stop or complain or sue the company because the machine is not working. The patient will not understand that. So no patient will understand why the machine is not working. They will ask the doctor what happened, you know, like you should be able to do it. So I think you're right. I think we should be prepared for anything. And enable technology, as I say, they're a tool, but not other than a tool. A better tool, but still a tool.
All right, thanks, Rodrigo. Any other questions? All right, excellent. All right, thanks everybody for joining us for our conference.